So our next panel is 5 speakers. The same rules will apply. We'll again attempt to keep right on time with the presentations, and I think as you can see now from the first 2 panels, some of the real value that we get from this roundtable discussion exercise is in the conversation. So really want to make sure that we have enough time for that. As we move into the afternoon, I'm going to remind you once again of the rule that we also have, is if you don't mention it, it doesn't get into the report. So I think we've made that point a couple of times informally as well over the course of the morning. So don't be shy to come to the microphone and make commentary as well as ask questions in terms of observations and so forth as we go along. And also during the morning session, I think we saw one member of the audience very nicely, courageously step forward and answer a question for the panel. And that's fair game too. It won't offend the panel, and it really draws upon the fact that not only do we have smart people that we've asked to do the presentations, but we have you also who here in the room that have a lot to contribute to this conversation and dialogue as well. So we have our first speaker, Dr. Diane Levin-Zamir. I hope I've got that right, Zamir. She's director of the National Department of Health Education and Promotion, Clalit, Israel's largest health service organization, and lecturer in health promotion in the schools of public health in Haifa, Tel Aviv, and Hebrew universities. She specializes in action research and health promotion and community primary care, hospital and media settings, media health literacy, measuring health literacy, and currently leads the Israel Health Literacy Survey. She is one of the founding members of the Israel Association of Health Promoters and Educators, and is an active member of the National Council for Health Promotion of Israel's Ministry of Health. She has fulfilled a number of leadership roles in the International Union of Health Education and Promotion, is chairperson of the Global Working Group on Health Literacy, and serves on the editorial board of the Global Health Promotion Journal, as well as editor of the hpsource.com for building capacity in health promotion. Following her will be Ms. Kristine Sorensen, researcher and project coordinator for the European Health Literacy Project, hosted by the Department of International Health at Maastricht University in the Netherlands, and is the focal point for Health Literacy Europe, the European Health Literacy Network. She is also engaged in other related projects, such as the joint venture on health literacy with CSR Europe, which integrates health literacy into business action and corporate social responsibility, and the study on health literacy and the right to access to health in collaboration with the Council of Europe. In addition, she works closely with members of the European Parliament, European Commission, and WHO office in Europe to establish health literacy on the European health agenda. At present, she is finalizing her Ph.D. studies at the Research School at Maastricht University on the topic of health literacy in Europe. Dr. Franklin Apfel is the managing director and founding partner of World Health Communication Associates Limited. His current work focuses on health literacy, M.H, scorecard and checklist development, and building public health communication networks to counter hazard merchants, brand health initiatives, and make healthier choices easier. Previously, he had worked as a head of communications for WHO regional offices in Europe, as primary health care fellow of the King's Fund in London, and regional director for Central and Eastern Europe project HOPE. He is a general practitioner and medical director, CEO of the California Health Leadership Incorporated. Next, after him, will be Dr. Fikry Isaac, who is the Vice President for Global Health Services at Johnson & Johnson. Dr. Isaac leads the development of health and wellness strategies, policy guidelines, and services worldwide. He's been with Johnson & Johnson since 1989, and for the past 10 years has been driving the competitive total health programs that have reduced the company's healthcare costs and improved the health of the employees. He serves as Chief Medical Officer of Wellness and Prevention Incorporated, a Johnson & Johnson company. In this role, he provides health management expertise, strategic direction, supports customer acquisition and lead generation. In addition to his MD, he received his degree in Master of Public Health and Occupational Medicine from the Medical College of Wisconsin in 2001, and as a fellow of the American College of Occupational and Environmental Medicine, where he chairs the pharmaceutical section and the Corporate Health Achievement Award. He is industry co-chair of the Life Science and Innovation Forum, and also serves on boards including the Partnership for Prevention, Global Health Benefits Institute, and Health Enhancement and Research Organization, or HERO. And then the last two, we have Dr. Michael Rosenblatt, who is the Executive Vice President and Chief Medical Officer at Merck. He's the first person to serve in this role for Merck. He represents the voice of the patient and medicine inside of Merck, and is the company's primary external advocate on medical issues. Prior to this, he held an appointment at the George R. Minot Professor of Medicine as the George R. Minot Professor of Medicine at Harvard Medical School, and Chief of the Division of Bone and Mineral Metabolism Research at the Beth Israel Deaconess Medical Center. He also served at Harvard as the Harvard Faculty Dean and Senior Vice President for Academic Programs at Care Group and the Beth Israel, and is a founder of the Carl J. Shapiro Institute for Educational Research at Harvard Medical School in Beth Israel. That organization has a joint venture whose mission is to manage the academic enterprise and promote academic innovation. So prior to that, he served at MIT and Harvard Division of Health Sciences and Technology, where he led medical education organization for students in training, professional students in training, jointly sponsored by Harvard and MIT. And prior to that, he was a Senior Vice President for Research at Merck Sharp and Dohme. He is, in leading most of Merck's international research efforts, he established basic research institutes, one in Japan and the other in Italy, and has also headed Merck's Research Worldwide University and Industry Relations Department. So, did I get everybody on this panel? All right. So, a World One, very accomplished panel, and we're going to start off with Diane, and she will have to leave to make her plane back to Israel for very important reasons right after her presentation. So I'm going to just say that so make her comfortable in terms of her presentation. So please go ahead.
Thank you very much. It's often challenging to be the first presenter after lunch because everybody just kind of settled back. So if anybody wants to stretch a little bit, or you can tell I have a health promotion background and want to get up and just wake up a little bit, that's fine too. It's also a good photo opportunity, so anybody who's doing the filming will have good opportunity for a nice visual. First, I'd like to thank the organizers of this wonderful roundtable for including us, including me. It's a real privilege to be here with such distinguished colleagues over lunch, even continuing to meet people who I've read about, heard about, corresponded with, and this is a wonderful opportunity to meet them. So again, thanks very much for the organizers and for putting this together, this wonderful program. Yes, I am from the Clalit Health Services, but I will also mention one more point that came up in the last session regarding ways in which we can stay in touch. And this is not the summary of the presentation, but as you see on the first slide there, I also put the IUHPE Global Working Group on Health Literacy. IUHP is International Union of Health Education and Promotion, and we've put together just a global working group of people who want to work together in different aspects of health literacy. So if any of you looking at the international perspective and what networking would like to be in touch and learn more about it, I'd be very happy to tell you about it afterwards. So as an overview for the presentation, I would like to, within the 15 minutes, which is probably only 14 minutes now, touch upon a little bit of a background about Israel, a little bit, some of the highlights of what we're doing in health promotion and health literacy in Israel, looking at a bit about policy, looking at action and practice, some capacity building and research, and a few recommendations that maybe can be a basis for any kind of discussion we'd like to have. Firstly, Israel is a country of cultures. I think culture was brought up this morning. That is what Israel is really all about. If we look at the breakdown, you can see that about 20% of the people who live in Israel are Arab-speaking. Another 20% are native Russian speakers. And the other 60%, basically many of them will be coming from other countries. And a growing number will be Israeli-speaking from birth. But it's not just the language, it's the different cultures that come together. And that, is, of course, presents a tremendous challenge for health services, for health literacy, for health promotion. Just a little bit of a profile of health in Israel. I'm not sure any of you have ever encountered any of the data, and it changes all the time. I think we're doing a pretty good job with life expectancy, ranks fourth in the world. Universal health care coverage is something that I think we're pretty proud of. As of 1995, there's universal health coverage for all citizens or all people living in Israel. That includes primary, secondary, and tertiary care. Risk factors, what we're seeing in the rest of the Western world or westernizing world, 20.9 or 20.3 to 20.9. Smokers very slowly, extremely slowly leveling off. Over 60% overweight or obese, 20 to 30% regularly engage in physical activity. But of course, if you break it down to cultures, we'll be seeing the difference. We'll be seeing that there'll be the Arab women who are much less physically active, Arab men much more smoking more, religious men and women much less physically active, etc. Average number of visits to physician about 6 to 8 per capita. We have growing rates of chronic disease, which all of you are very familiar with. Although we have a very low GDP for healthcare, we are having increasing out-of-pocket expenses for health, and we're worried about creating disparities. So these are definitely challenges that we're trying to deal with. This slide is only here just to inform you that as we enter the OECD last year, more and more of our health indicators are being compared to other OECD countries, and here you can see that Israel ranks 11th in smoking in the OECD, and a number of our measures have been compared. Regarding literacy, for whatever we know that it contributes to health literacy. We know literacy is not health literacy, but we're often asked about it. So I thought it might be important if we know something about literacy in our countries. And Israel ranks about 67 with a literacy rate of 97%. That was measured by the UNDP. It ranks about 17 in the world among 192 countries for digital communication, which is really getting much more and more prevalent. Regular use of internet, 68% to 80% of the households will regularly use internet. As far as the working definitions of what we use, I think none of these definitions are foreign to any of you. I think we're looking at more and more of a combination. I enjoyed some of the other definitions we saw this morning that had an issue of expectation in it. I'd very much like to explore that as well. But as we're basically talking about more or less the same definitions that are meshed together. So just to go into a little bit of what has been done. I will start with a few policy landmarks just because I think one of the things that we can say about what's being done in health literacy is that we're looking for the best opportunities and we're looking for the ways in which, in an integral way, health literacy can be brought to the fold. We're not yet seeing a national initiative for health literacy and policy for that. But we are seeing developmental goals on health literacy in the 2020 goals and objectives, a national strategic plan for reducing health disparities that has health literacy within it, a very new directive for the Ministry of Health. The Director General has given an unfunded mandate on cultural and linguistic accessibility of the health system. As you can see, we're talking about cultural mediators, so on and so forth. And this is going to be a big challenge for us to meet this. The whole system is supposed to be culturally and linguistically accessible by February 2013. So you're all invited to help us. We have a voluntary adoption of the Joint Commission International Accreditation by the hospitals of the Clalit health system, within which we're seeing more and more demand and needs that are blossoming and definitely coming to the front about health literacy. So the policy is where it maybe begins, but In parallel, there are action points that I'd like to mention that we, in a sense, didn't wait for policy to be put in place if we saw that there was opportunity or we see opportunity for action. So I'd like to focus on a few settings. Some of the discussion that there was this morning reminded me of what we do often in public health and health promotion is look at settings. And I think that was the answer maybe to some of the questions that came up, what is the scalability and where can we reach people where they are. I think looking at settings is one of the important aspects of what we do. So I'd just like to mention very briefly a few examples, just really some tastes and sounds of some things done in community primary care and hospitals and even in the media. Most of the experience that I have will come from Clalit Health Services. As it was mentioned, we're the second largest non-governmental health organization in the world. Israel, which is a small country, 7.8 million people, in a country about the size of New Jersey, but it is the second largest organization, second to Kaiser, and our colleagues here from Kaiser, of course, are number one. And it's for historical reasons, the way in which the health system infrastructure was designed in Israel. So we have 35,000 workers, over 1,300 primary care clinics, 14 hospitals distributed around the country, as you could see, many other services, and this is a good basis for working in an integrative way on the issue of health literacy. So I just give a few examples of some of the action plans and some of the action pieces that we've put together. We have a national plan for initiating and for reducing disparities. And one of the aspects that we have developed and have been able to sustain is partnerships for health promotion within this very strong health literacy piece for new immigrants. We were fortunate in being able to partner with the Ministry of Health for being able to train, to locate, train, employ cross-cultural liaisons, mediators in primary health cares. I think our Italian colleague mentioned it this morning. It's a program that we call Refuah Shlema. It includes an integral part of the team is a cultural liaison serving the Ethiopian population. This is where we first tested this model. We partner with NGOs to do this. We have telephone translation as well in Amharic. We have a special community diabetes program, and we also train and coach health staff on cultural competence skills. And this was published last year in Global Health Promotion, if any of you want to see the data and want to see the article itself. After the first 5 years, we initiated this in the late 90s. At the first 5 years, we did a 5-year evaluation. It was actually a clinic-controlled study, and we saw that the major findings were the program was effective in improving physician-patient relations when we're talking about new immigrants, improving availability and accessibility of medical services, improving ability to navigate the health system, and we did not see any increase in expenditure on services that were incurred. And I think that is a very important point because it hasn't come up that much at the discussion so far, but it probably will, and I think it's on all of our minds and all of the policymakers' minds. And it's been the longest sustained program that we've had. It's been working for 14 years, the longest community program for cultural mediation that's been implemented in Israel to date. And we're trying to use that as a model for other programs. Another action point that I wanted to mention was the issue of diabetes and chronic illness. Just quoting Renders, we see that no one specific intervention, if used alone, leads to improvements in management of chronic diseases. So we know that a complex problem will only be solved with a complexity of solutions. And we have put into our quality indicators, our national quality indicators program in the community, we've added disease management for diabetes, CHF, hyperlipidemia, hypertension, and rehospitalizations as quality indicators. And working back, we're looking at what interventions, including working on health literacy needs, we need to do. So looking at the overview of strategies for diabetes, we've been working very strongly on health literacy tools, in-service training for doctors and nurses. We've been doing this consistently for the past 10 years. Over 3,000 doctors and nurses are every year are trained for another aspect of treating diabetes. We're running lifestyle and self-management workshops that are culturally appropriate and have been developed along with groups of community citizens and people from the community in an empowerment framework in order that the self-management workshops will be more adapted to their needs. And we tailor programs for special populations. We published the data about the 12-year follow-up from this program last year, and if any of you would like to see the data, you can see it in the article. Just giving you an idea of how we're expanding it every year. From 2006, it started earlier, but from 2006 we've been following it with data, looking at the scope of the workshops and the healthy lifestyle and self-care, and the extent to which the importance of being able to access, understand, use information for the health, which is a strong health literacy piece, has been contributing to it from year to year. If we look at the effectiveness of outcome measures, looking at HbA1c measures for diabetes balance, then we see that we're seeing that compares before and after, and those who haven't participated in a controlled model, we're seeing great improvements in the measures, and we measure this 6 years after. So when we put the health literacy component into it, we want to be able to gauge it and see what it's contributing. Going from the community to moving into the hospital area, I'd like to mention that we have two main, I would say, health literacy initiatives that have been part of and have been basically embraced by other very large initiatives. Most of you probably know about health promoting hospitals, and we have Professor Jürgen Pelikan here, who I think was of the initiators and has been the lead of this initiative for is it 20 years almost now? And I'm very happy to say that Israel recently joined the network of health promoting hospitals, within which we're able to talk and create the dialogue about health literacy. Once we call it a framework, then we can speak about health literacy. And this happened in tandem with the Joint Commission International giving accreditation to Clalit hospitals and kind of recognizing the excellence in patient education, and there is also a health literacy piece. So we're looking at special initiatives within which that we can add the health literacy initiatives, and I think we're looking to improve and we're looking to promote health literacy. Our experience is that when we work with other initiatives together, it might sound opportunistic, but it becomes more integrative. We're able to take it further. We tried, and we introduced ASME 3 in Israel last year. It's been translated to Hebrew, to Arabic, to Russian, and we initiated into both community care, pediatric clinics and gynecological clinics in the community, and also to our teaching hospitals. The clinics in the community didn't feel very comfortable with it because they were saying, well, we have open communication with our patients. We don't need them to be directed to ask us questions. They do it, and we measure that, and they were right. We didn't have much room for improvement, but in the hospitals there was much more of a take-up of the program, and so we're looking at it. We're trying to do the Teach Back program as well. One more initiative that I wanted just to mention as far as action is that we have a tremendous program now of health literacy online, Hebrew, Arabic, Russian, French, Portuguese, health information. You can get your health examination results. You can get interpretation of the results. You can make appointments in all of these languages. We have 2.5 million entries every month. About 80% of them are unique entries. So we're getting more and more people involved, and not only members of Clalit. It could be anybody in the country, anybody around the world who wants to go in and see it. I will not show this little game that I wanted to show you because we're running out of time, but if you go onto our website and you see this presentation and you play, there is a link, and we're now trying to engage kids in understanding more and getting better information about nutrition through a special game, and it was an app that was the most popular app in all of Israel in the past month. And any of you know that it's a startup nation, you know that this is a pretty good accomplishment. So just to move on, health literacy and capacity building, we were very fortunate to get a grant from Glaxo and Pfizer to build a computer-based module for teaching and improving communication skills in primary care teams, motivational interviewing and brief interventions, and you could see the different topics we worked on, and it is on communication and communication better, and we've had over 1,100 doctors and nurses in the past year have gone through it. And my last point is about research. We don't want to give up our research potential, and we're building a research base. The first piece of research that we did was develop the model of media health literacy. It's a media health literacy scale that was published last year in Health Education Research. research, and it's a model that was built basically on the nut bean model that was a bit adjusted for media, and we were able to show that it was tested among adolescents in Israel. And we showed the association between media, health literacy, and other very important aspects of health and health empowerment that you could see. So, and the last point I would just like to make is that we're very proud to be part of to have the National Survey on Health Literacy in Israel, that is kind of a sister survey or a cousin survey to the Health Literacy Survey in Europe. And Kristine will be presenting now the initiative. It's face-to-face, 600 people, Hebrew, Arabic, Russian, and Amharic, and it's based on focus groups with key informants. So just in summary, we do have tremendous challenges for bridging health literacy gaps in Israel. We have new and very preliminary policy initiatives for health literacy. It's a systems approach. It's complex. We're looking at the complexity of health literacy action. And research is in its early stages, but we're going to definitely take that forward. So if we would just like to make our recommendations and our contribution to the discussion, we think we would like to look more at striving for health literacy in all policies, kind of prevent the silo effect, collaborate in research, build on experience from colleagues and partners, which we have done up until now, and I hope after today we will do more, and have international initiatives for professional training and capacity building. And I want to thank you all. I want to wish you all a happy new year whenever you start your new year. The reason I have to rush back is to be back for our holiday. So thank you very much once again, and I wish you the rest of have a very, very fruitful rest of the discussion. Thank you very much.
To start your new year properly.
The European Health Literacy Project has manifested health literacy in Europe. Before the project, there was a lack of data at national levels and cross-national levels, and there is certainly a lack of funding. However, due to a very persistent group, a handful of people in Europe who could work together and join forces, led by Ilona Kikbus, who's sitting here in the audience, and Helmut Brandt from Maastricht University, they managed to make an application to the European Commission for funding, and we got the funding to start a project in 2009. The project was led by the European Health Literacy Consortium, a consortium of 9 institutes and universities from 8 countries: Austria, Bulgaria, Germany, Greece, Ireland, Netherlands, Poland and Spain. And together we worked for 3 aims, or to achieve 3 aims: to set up national advisory boards in the 8 countries on health literacy, to establish a European health literacy network, and to measure health literacy in Europe. And it's the last thing that I would like to share with you today. So what we did in our group was to discuss what is health literacy. And we wanted to look for a tool that could measure health literacy in populations. But we didn't find it, and we had to develop a tool on our own. So what we have made is a tool called the European Health Literacy Questionnaire, HLS-EUQ. It's a conceptual-based tool. It's developed by a multinational cross-disciplinary group of researchers, and it captures a broad scope of healthcare, disease prevention, and health promotion. It reflects what we had earlier today also, that it's fitting the model of Ruth Parker, capturing the individual competences and the complexity of the systems. It's content and context specific, which NotBeam has emphasized. And we have developed it in 3 versions. A long one used for the European Health Literacy Survey. A core part of it, the 47-item version, is on health literacy, and a short version with 16 items. At the time being, it's translated into 10 languages, and we have more translations in progress. It's applied already in the European Health Literacy Survey and in smaller studies in specific target groups. So In the next couple of slides, I will show you the journey we carried out to come this far. We made a literature review of definitions, and it was not to go our own way, but to build on the work already done. And this is our version, and it's an all-inclusive working definition where we try to capture all the dimensions we could identify in the existing definitions. And it says health literacy is linked to literacy, and it entails people's knowledge, motivation, and competencies to access, understand, appraise, and apply information, to form judgment and take decisions in everyday life in terms of healthcare, disease prevention, and health promotion, to maintain and improve quality of life during the life course. We also made a review of conceptual models existing and combined them for this working conceptual model for our survey. And you see in the center that we have the 4 steps of processing information, accessing, understanding, appraising, and applying information to take decisions in terms of the three areas of health, so in healthcare, disease prevention, and health promotion. To the left-hand side, you see that it's influenced by personal determinants, social determinants, and a broader environmental context. To the right-hand side, you see the outcomes, so it has an impact on health service use and services in general, on health behavior, on your engagement in society, and it's also a matter of social justice, so equity and sustainability. To the top, we have drawn the life course line. We think it changed over lifetime. And the model captures the individual competences as well as the public health perspectives. Because this model I show you here is from the public health perspective with the healthcare, disease prevention, and health promotion. But if you look at it from a personal point of view, you could write that when you are ill, or when you are at risk, or when you're trying to stay healthy. So we believe it's two sides of the same coin. In order to develop the questionnaire, we operationalized it with this matrix. So we found 12 sub-dimensions of health literacy, and we developed items for each of the 12 sub-dimensions, and these are some examples. So, for example, within the healthcare domain, on a scale from very easy to very difficult, how easy would you say it is to find information about symptoms that concern you? Going to the next dimension on understanding, how easy or difficult would you say it is to understand your doctors or pharmacists on how to take prescribed medicine? How do you judge information from your doctor and how it applies to you? And how do you follow the instructions on medications? And that system goes all the way to the disease prevention, where we use the example of vaccinations, on health promotion, where we took it on nutrition or exercise, or the broader life perspectives. The results were analyzed using a new scale developed by our chief analyst, Jürgen Pelikan, who you will listen to later on. And if you have any questions concerning the analysis, please go and find him in the break. He's here to explain and support. And the scale was turned from the 47 items into a 50-point scale. And we identified 4 levels of health literacy. So those who could say they found it easy or very easy to answer the full questionnaire, up to only 50%, they would have an inadequate level. Those who could answer very easy or easy up to 66%, 2/3 of it, would have a problematic level. Those who had 80% had a sufficient, and the rest, the top 20, would have an excellent health literacy. And this is our main result. The General Health Literacy Index for our 8 countries showed that 47% on average had either problematic or inadequate levels. That's across the 8 countries. But you also see that it varies across the different levels or the different countries. So Netherlands is doing well, and Bulgarian is the one where having the most severe levels of low health or limited health literacy. We also saw that it was associated with age. The purple line the top line is Netherlands, and there it seems that it has no impact, age, but for the others, you see that health literacy is lowered with age. There is a very strong social gradient in the European sample, and those with very low socioeconomic status seems to have a limited health literacy as well. It's also linked to self-perceived health, so those who rate their health as bad or very bad health have also low or risk of low limited health literacy. And to put it into a broader perspective, what does it mean? And what is the role of health literacy when we talk about health and health systems and health policy in Europe? Well, we can certainly see that health literacy is a challenge, a general health challenge in Europe. And it's context specific. It varies across countries, which also demands local solutions. We saw through our work in the European Health Literacy Consortium that European collaboration is an asset. When we're working together, we are suddenly a platform that people can approach, and people from other organizations, so WHO, Council of Europe, European parliamentarians, approach us for advice. And we suddenly got an advocacy role, even before we had the data. We saw that it varies across countries, so national and local solutions are needed. And there was a question earlier today, what's the difference? And are there any particular, it was Irish or Spanish or Bulgarian aspects of health literacy? And we are now diving into it, so our national teams are diving into the national data. But we can see, our hypothesis is that it's the health systems and the society shaping the levels of health literacy. Where can people find information? Who are the gatekeepers? What are the national beliefs? Religion, societal impact of educational system. It's very, very complex. But we're diving into the data now, writing journal articles, making also bilateral studies, so we hope we will come up with more clarity in the years to come. The project just finished here this year, but the next wave is already secured. We have our Health Literacy Europe network, that would be the new platform for action. That is where we will take the next steps. We are working with additional countries to implement the European Health Literacy Survey. We are trying to have it into mechanisms already existing, so the Eurobarometer, which is a tool that measures health in Europe in different aspects. We are trying to work with educational institutions to have it into the curriculum. We are working with politicians to have it on national agendas. And we are looking for cases where we can promote it. So, for example, Austria has now made health literacy as part of the national health targets. So we promote that and show it to other countries to pick up these best practices. So health literacy has been manifested in Europe, but it wasn't such a glamorous picture as we had hoped for. 47%, is that meaning that the glass is half full or half empty, depending who you ask. But there is certainly something to do, and we should do it. We need to do better. We are welfare states and have well-functioning educational systems, so this number is just too high. And we are trying now to work together, and this first consortium and the first project has been a success. And we are now very happy that we can come here and share the results, and I look forward to the dialogue we have here with the Roundtable on Health Literacy, and hope that this will really take us also to a global platform. So thank you for your ongoing support in this mission. Thank you.
George, is this changed by itself? Nice, thank you. Does this change by itself, or?
You have to push the little arrows or use the
Yeah. No. This is the same.
You got it?
No. Oh, yeah, I got it.
Good afternoon. My name is Franklin Apfel, and I'm going to talk to you a little bit this afternoon about health literacy communications. And let me just say that I am so happy to be here at what I consider an immensely historic meeting where the great and the good of health literacy around the world have come together to redefine themselves as a global health literacy community. And what I really want to share with you over the next 15 minutes is 4 messages which I think will help us in terms of this goal. First, I want to talk generally about communicating health literacy, and I want to present a message, don't hem me in. Second, I want to revisit some issues related to measurement, and I'm going to talk about democratizing our measurement tools. Third, I want to talk about marketplaces and our ability to fight what I call health gliteracy as opposed to literacy, and some new opportunities and challenge in how we can be universal connectors. So what are some of the unique features of health literacy that have allowed us all to engage or to be attracted to this particular area? Now, I know that Andrew, in his paper, is that massive, wonderful paper, moans about the fact that there is no universal consensus of what is and is not a health literacy project or policy, that there's no global organization for health literacy, that there's no actual population of interest, or the actual population is undefined, and there's no universally equitable means to translate the concept of health literacy. What I would like to say is that all of those characteristics are really what allowed us to get here. The fact that we had no universal consensus, that there was no global organization, that there was actually, the population of interest was undefined, that there was no universally equitable means to translate, allowed us all to start pursuing and engaging and trying to find some definitions that we could work with. So the process has been what I consider more viral, admittedly a very slow-growing virus, than a controlled process. But it's been dynamic. And it's been growing, changing, expanding. We started out with issues related to compliance and health services. And now we're talking about advocacy and community engagement and talking about all areas of risk reduction. And now I'm trying to push a new framing in regards to the fact that we consider ourselves global health citizens. And health literacy, we need to see ourselves as global. That we can't be seeing ourselves that what happens there affects here, and what happens there affects us. So looking at ourselves more as that global community. And we need to understand that we're trying to deconstruct health systems so that they can get more intersectoral, that they can be more expansive. And here we have something with health literacy that's already established that. And we have multiple champions. Many sectors, disciplines, settings, and levels have engaged in it. So I think that we have a very refreshing lens that we can look at stuff with, and we don't want to lose it. So my first message is, don't hem it in, which tends to be a bit of an American expression. And for those with the majority language in the world, which is, well, it's probably the second, non-native English speaking, don't hem it in may not mean anything, but basically it means let's not restrict it. Let's keep it open and let's not over-structure it. Message 2, communicating through measurement. What gets measured gets done. Ruth has said this a million times and has engaged us in that notion. And this is for sure true. And all the work of the IOM and many of you in terms of what we just heard about with the European health literacy study has provided data and a scientific basis to advocate for attention to this issue. Vital. Very important in terms of those various measurement tools. It's raised awareness, policy advocacy, monitoring, and impact. It's given us some scientific authority. But it's been very provider-driven and research-oriented and practitioner-oriented. And it's been very focused. If we look at this dynamic that Ruth and others had developed of the skills and ability versus the demands and complexity, it's been very focused on the sort of skills and ability side. Now, there have been some increasing emphasis to shine some light on the supply side and outputs with some checklists and some wonderful work by Kari Jakobsen about assessment of how well systems are relating to health literacy. But what I think is that we need to start looking at ways that we can give people tools to hold systems accountable, to make sure that their systems are more health literacy friendly. And that's why we've been putting a lot of attention into developing what we consider some simple outcome-focused tools, scorecards, which could be widely available and could be implemented and embrace notions around citizen science and can have both an individual and a system focus. What is an example of what I'm talking about? What I'm talking about here is that we have with an NCD system scorecard, we look at the WHO best buys. And the best buys basically are talking about interventions that people can engage in that have been shown to be very effective, both cost-effective and also save lives. So based on those well-documented, evidence-based best buys, we create a scorecard. And we've been talking with the International Alliance of Patient Organizations, with the WHO Healthy Cities movement, about instituting some kind of systems-level scorecard so that you as an individual, we give you this scorecard and we say, okay, is your institution, is your community, is your nation really providing you with the kinds of policies and implementing those policies that are known to make healthier choices easier? So we give them a scorecard to rate about tobacco control policy, alcohol, salt, trans fats, exercise. And they get a score, and then maybe we could have a 5-star city, a 4-star city, an institution that's really trying to make healthy choices easier. We're also looking at some individual scorecards, and Scott earlier talked about some of those, where individuals can look at some of their own metrics and as outcomes of their health literacy, and then start raising awareness and having some notion about things that they can do about those. And there's quite a lot of benefits to some of those individual scorecards. A single number means easy for people to keep track of their health, establishes simple goal ranges, includes a range of medical and health indicators and behaviors that helps people create a mental model of how to make lifestyle choices, and NCDs are connected, etc. But more important, I think, is that we can aggregate those scores so that, again, we can hold the systems accountable. So if this population from this geographic area or this institution has high scores, they seem to be doing well, well, then that institution is providing the kind of health literacy-friendly environment that we're looking for. But if they're not, maybe we need to put some input into that. So what we're talking about here is message 2 is let's democratize measurement. Let's give people tools that they can hold their systems accountable. Number 3, health information marketplaces. We're not operating in a green field here, ladies and gentlemen, okay? We're talking about health literacy, but there are a lot of people out there that are trying to promote health illiteracy, or health gliteracy as we talk about it. And what are we talking about? We're talking about hazard merchant domination of health information marketplaces. Who are the hazard merchants? There's the arms industry, the tobacco industry, drinks industry, fast food industry, that are putting major investments into ensuring that people are choosing their products as opposed to health. They're choosing risk as opposed to, and hazard as opposed to health. So when we can't just focus on the health literacy part, we also need to be thinking about how we can counter those. And certainly, she who controls the frame controls the debate. And framing is a very key issue. So the tobacco industry was very successful in framing issues around rights, the right to smoke. And anyone who was talking about their not right to smoke was considered a health fascist. All right? So when we were working on the Framework Convention on Tobacco Control, we needed to reframe the notion about tobacco as a rights issue, but to make it more of a public health issue. So we had a motto was, tobacco kills, don't be duped, don't be fooled by an industry that's trying to manipulate you and stuff. Same is true in terms of immunization issues, where we're talking about the immunization skeptics, keeping the debate, framing the issue around safety. Safety is important, but the issue of immunization is not so much about safety, it's about protection. It's about protection about real threats and diseases and stuff. We need to reframe that around protection. So we can learn a lot from the hazard merchants in terms of their skills of how they're able to manipulate people, but we do it in a more positive way. So we learn stuff about social marketing, audience-centered communication, segmentation, channel selection, persistence. So changing our mindset. So we're not just delivering information to audiences, but we're starting with the customers and we're trying to gain some insights, and then we're shaping our messages to those audiences. And that really addresses the question that was raised earlier in terms of how do we deal with immigrants or minority populations. We're talking about really understanding people's perceptions and shaping our messages and developing our programs with them from the very beginning in terms of planning through to implementation. We can reframe stuff, and there's some really exciting and interesting stuff about reframing messages and making it that less is better. Campaigns, people running in many countries to raise awareness about issues. Education campaigns by different groups, patient groups, information to Head Start programs, NGOs, about how to get raise people's health literacy and action, learning a lot from the hazard merchants, and then putting and integrating those communications into comprehensive programs. So, third message is counter health gliteracy, all right? And we all want to be as sexy and as intriguing and attractive as some of the messages from our hazard competitors. Finally, I'd like to focus on the fact that, and we've heard lots of examples of this throughout the day, that there's a mass communications revolution going on. We're all aware of that. And we need to be in the center of that or be partaking about that. I was very pleased to get an email from Ilona Kickbush earlier this week saying that she's now opened a Twitter and a Facebook account. And I'm an active follower of yours already, Ilona, all right? And I gave you a thumbs up on your Facebook page, all right? But the reality is that we need to be engaging in all those various, new social media tools. Because we need to, where people get their information has changed and what influences health literacy is changing, and there's many, many opportunities and challenges. So that on the one hand, and this is an old slide, I just learned already today that it's not 2/3 of the global population, it's 3/4 of the global population now has mobile phones. But we also see that there's a media consolidation, both globally and nationally, and getting independent information is harder in many respects. So we have challenges and opportunities. But global reach, internet, we have new platforms galore. This is a Patients Like Me platform where people can communicate with other people with similar kinds of health conditions and diseases, and they can help each other and inform each other and raise each other's health literacy about what are some of the options people have. We heard some about some of the various text programs. This is the Text for Baby program where a mother will text in her due date and will using geocoding and due date, they'll start getting some messages and referrals to local resources of support. And covers all sorts of different topics and the kinds of messages that people are getting, trying to develop some kind of relationship with people. Congratulations, you're going to be a mom. Text for Baby wishes you a happy and healthy pregnancy. Thanks for including us in this special time. I mean, really trying to craft messages that really engage people and start developing a relationship with people, but also providing some very good scientific information and becoming a referral source to various services, community-based services. This is one of my favorites is Love Clean Streets. If you are walking down your street and you see rubbish piled or a lot of dog poo on the street, you can text it in to your local authority and it gets registered on their website and they take care of it and you can follow the progress of that. Citizen science. This is also happening in developing world as well in terms of gathering data about different infectious diseases and doing monitoring of health interventions. Vaccinate Your Baby, a Facebook page, kind of countering some of the information from some of the vaccination skeptics. The IOM's health literacy video, there we go. We are using YouTube to communicate. I have a son who doesn't read. He gets all his information through video digitalized formats and stuff. He's a very bright guy, and it serves him well as a bartender. Edutainment, where we're trying to use soap opera formats, storybook formats to communicate health messages. These are from the Soul City group in South Africa, very well accomplished edutainment program, very well researched, and introducing health themes and giving good information about health. And then this slide here, this is another one of my sons here, and you notice that lump in the left side of his pants down there? You see that lump? He's not glad to meet you, everybody. That's his, sorry about that. That's his mobile phone, and actually, the reason I raise this is Dr. Alexander Apfel, and since he went to the Brighton, Sussex Medical School, one of the new medical schools in the UK, and as a third-year student, all the students got handheld devices, and he hasn't had a textbook since his third year in medicine. Everything has been over his handheld devices. So the health literacy issue is not just about individuals, it's also about providers. He has all of information at the bedside, and he uses this. And that's the basis of his resources in terms of health information. So what I want to say as a fourth message is let's be a universal connector. Let us use our capacities and knowledge about these various interventions and our various experience, that we start linking people around the notion and use health literacy as a platform to develop this global health community, as Joe Ivy Buford opened this meeting with. And indeed, I think health literacy can be that linker, and all of us as a community can help make a better world with that. Thank you very much.
Dr. Isaac?
Well, again, it's a pleasure and an honor to be here with all of you, and to really be part of the distinguished speakers for the day. It's really fantastic, and I appreciate the invite. What I'm going to talk to you about today is really looking at it from a corporate perspective, from a private sector perspective. What do we do in the area, whether it is specifically related to health literacy versus looking at the holistic approach to health and well-being within a corporation, and share with you some of what we do within Johnson & Johnson globally, why we do what we do, what some of the program we offer, what's our philosophy, what's our outcomes, if we have any, and what are some of the, the areas we try to explore as we address the population health need of Johnson & Johnson employees. So let me just start by saying, within Johnson & Johnson, my responsibility covers 120,000 employees around the world. 60% of those are outside the U.S. Add to that, multiply that by 2.5, that's their dependents and family members, and then of course extend that to communities where you maybe even have a bigger reach. So quite a bit of community to cover, quite a bit of responsibility. Johnson & Johnson is very decentralized, 250 operating companies around the world, operating in 75 countries, or manufacturing in 75 countries. But what really brings them all together is the credo, the value system within Johnson & Johnson. It is developed and established about 65 years ago by General Johnson, and essentially set the stage for what it's all about, why we do what we do. And it is all about the patient, the doctors, the nurses. It's about our responsibility to the men and women working for us. It's about our responsibility to communities, the environment, and then lastly comes the shareholders, where if they do all of the above well, they will get good return. And that's keep us really on charter for addressing the health needs of our population. Now, as we set the global health strategy within Johnson & Johnson, those are really some of the key things that have worked for us. One, it is about a culture establishing, promoting, and sustaining a culture of health within an organization and finding the right, let's say, remedy that incorporate all of these things so it becomes part of the fabric of the organization versus it's an add-on, whether it's a health information platform or whether it's an intervention or whether it is some form of events that come and go over time. The other thing that really we thought helped us in our setting our strategy, it is about that holistic view of the individual and the organization. And really, it's about us offering programs that do connect to each other, looking at it from mental, physical, nutritional, spiritual, mental type of approach versus taking one area or one condition and addressing that condition. Certainly using incentives just to bring people in, to get them interested, it certainly is not the way to sustain behavioral change. It is all about people really motivated to make a change in their lifestyle, which is really a lot of our key focus is prevention, and behavioral modification is the theme we follow throughout the last 30 years or so in this journey. Certainly committing for the long term is a key thing that as you put any program within a country-run program versus a private organization or communities, that's what you really need to establish as part of your strategy. And lastly, certainly you cannot address the individual even though they spend most of their time at work. You really have to reach out to the homes. You have to reach out to communities where they live. Otherwise, it may not, your effort might go to waste. I think I heard it mentioned earlier today about meeting people where they are. That is really part of our philosophy in offering programs. It is meeting people where they are, not where do you want them to be from a corporate perspective. We do this through offering those types of multimodalities approaches from high touch, person to person, face to face within our facilities, within our clinics, within our fitness or wellness centers or energy break rooms, to really offering behavioral change programs that are either offered in a mobile health format or in an e-health format, or certainly supporting the environment where they are operating to allow for this approach. Some of the approach we took here is based on us doing a lot of consumer insights and addressing or learning what are the pain points within corporate health management program, and really circles about issues of engaging the population and getting them to participate, about integrating programs as well as data. It is about making an effective behavioral change in the population, and certainly, as mentioned, outcome measures and then scalability to your entire population. I'm not going to take you through those programs. I'm sure this could take us a couple of days to go through, but just to give you an idea that it is an approach that covers trying to keep the well, addressing the ill and the injured, managing the chronically ill, and also address the high claimant or high cost individual through this approach we follow. Now, committing for the long term, as Dr. Rassner mentioned earlier this morning, we have actually been successful in incorporating global health goals within our sustainability Healthy Future 2015 direction. As you can see, there are 3 here. That's the only 3 I was able to get in and get them approved by our executive committee. And really focusing on, 1, allowing our global population to have access to what we call culture of health program, from policies related to tobacco-free to HIV/AIDS management, to wellness, professionals and access to EAP professionals or mental health professionals, to addressing awareness of how to prevent cancer in the workplace, how to address healthy eating in the workplace. All those are under the culture of health programs. The second and the third goals really talks about individuals' ability to understand and know their numbers and know their health risk and actually do something about it through either our own offerings or reaching within their communities and then within the health systems that they have close to them. And the last one, it is about globally, how can we show that we are making an impact on our population, reducing the high and the medium risk to low risk. This is just to to share with you. We track and monitor over time our performance on those 3 key goals and objectives across all of the enterprise globally, and it is a mandate to conduct this analysis on an annual basis, see where the gaps, where are the reds, the yellow, and where are the greens, congratulate the greens, encourage the yellow, and really talk to the ones with the reds to say, you're going to need to do better than that. This is really a platform we use and shared at the highest level between the CEO, senior management, but also across each of the business units across the globe to share with them their performance. As said earlier, again, think globally, act locally. These are just some examples of some of the effort we do around the world in Japan, India, the Philippines, and certainly in North America, where I'll share some data with you. But it is about us offering access for employee to centrally provided resources and tools that makes it easier for them to implement at the local level, customizing it to their need while ensuring consistency in what we give them and allow them just to design it to their culture needs. As I mentioned, involving communities as well as families is critical, and these are some of the touch points where we reach some of the family members as well as some of the communities of opening our fitness center for community folks living there, as well as allowing some of those programs to reach the home, reach the spouse, reach the children, and it has been working very well in offering some of those challenges as family challenges. I mentioned population health risks. That's how we look at the globe and our overall population. This is just the health risk assessment process we have put in place over the years, allow us to really look at those 11 indicators on the right side, from obesity all the way to depression, and really measure our population progress and percentage. And that is very important when you design programs, so you really put your investment and your energy where it belongs. Certainly, we're able currently to expand this offering across 19 countries as well as in 18 languages, and they were locally culturalized to the local needs for those countries. And it seems this is certainly, if you look here, the 3 top apparent risk factors that we have seen across the globe, not a surprise, but really essentially obesity, unhealthy eating, as well as physical inactivity. Now, the U.S. program has been in place for over 30 years. We have rich data that we share on a national as well as international level. And you could see here our population in the U.S. This is our health risk assessment, and shows you that we are trending. The low-risk population are going up from 78% in 2006 to about 88% last year, and also bringing the medium and the high-risk population down. And high, medium risk, the low risk is people who might have a 0, no risk, up to 2 health risk are considered low risk. And it's basically a comparison against some of our benchmark as well as the U.S. Data to show you we are making, certainly bending the curve on healthcare issue, but also really improving people's modifiable risk factors. I'm not going to spend too much here, but these are some of the new modalities we're addressing in the workplace, putting kiosks where people can just step on and do quick measurement of their blood pressure, their heart rate, talk to the screen, and do through touch screen, and get their own report, as you can see on the lower left side, and us be able only to look at it from an angle of, are people really going to use it again and again and again? We conducted pilots in the UK as well in France, and it seems it's well received. Whether we will continue to put them elsewhere, we're gonna see. I'll let you know next time. Other approaches I mentioned, digital health coaching is one of our own internal programs, and it's really about providing that accessibility as well as scalability for your own virtual coach on an ongoing basis to help you in a detailed assessment, but also plan for treatment and management as you see fit for whatever your needs or what you see important to you as an individual. The last innovation area we have been implementing at Johnson & Johnson has to do with energy management, really addressing energy versus time for our senior leaders as well as all of our employees on 4 dimensions, as I mentioned, nutrition, physically, mentally, and spiritually, and really scaling it up to be launched across the globe. Currently, we reach about 16,000 employees. They go for a training, either a half a day, 1 day, or 2 days, to teach them and take them through the journey of how to expand their energy beyond their current status and how to perform well at home, at work, anywhere. I'm not going to talk about our publication. This is one of several we published last year. This one was in Health Affairs in 2011, which really talks about a return on investment of having programs for the longest time, and are you able still to achieve better results? And certainly have been showing a return on investment by doing this of close to $4 for each dollar spent in those programs, as well as saving per employee per year, reduction in the rate of increase of healthcare cost, as well as pharmaceutical for the Johnson & Johnson population in the U.S. There are several other articles, Journal of Occupational Medicine, as well as the Harvard Business Review review last year, talking about some of those outcomes. And I encourage you, if you don't have them, to look at that. So lastly, I want to leave you with these some takeaways. One is I'm really focusing on a culture of health versus purely focusing on health literacy. It needs to be built within a fabric of whether it's policies or processes and or businesses to be able to sustain it for the long term. A really phased approach is critical to successful implementation. We learned that through the years. Setting short and long-term goals is critical. And then really addressing the modifiable, the preventable risk factor in any community or any country will have a significant economic impact at the work site, but also within economies overall. And certainly lastly is that investing in prevention and looking at new health innovation in the area of non-communicable diseases can yield significant economic and social return. I thank you for listening. I know it's a quick run, it's a snapshot, but thank you for the opportunity.
Great. Well, I think Dr. Apfel said at the beginning that this is an assembly of the good and the great, and I certainly agree with that. I'm not card-carrying in this field, so I'll introduce myself that way and say that I am, however, very excited to be in this field because I have a deep appreciation of what all of us can contribute to the health of our patients. And so it's not only an honor for me to speak here today, but it's also an opportunity for me to learn. And I've enjoyed the panel very much. I hope I'll have a chance to share with you in the next few minutes some of our viewpoints. I'm also acutely aware of the fact that I'm the last speaker on the program, and so consequently I chose not to show any slides. I thought that at this point in the program you were either going to listen to me or take your postprandial siesta, and my showing slides wasn't going to help you with that decision. I thought that I would speak to you a little bit about what industry's unique role can be in the whole health literacy movement and tell you about the journey that we are making at my company, Merck. And of course, I come to you from, you're all at the final and very important stage of having patients understand their medicines and how to take it and how to really take control of their own health. The world that I've spent most of my time in is the world of discovering new therapies and new vaccines. It's the beginning of the process, and frankly, we've been too slow at building the bridge to the world that all of you have been very active in. But we're doing it now. We've spent about the last decade doing it. And I would say that, you know, one step along the journey was coming to the realization that our products, our medicines and our vaccines, aren't just the chemical or the mixture that's in the bottle, but all the information surrounding it. And in fact, the chemical would be of no use to a doctor unless the doctor understood what was in there, what it was good for, and what would be the problems or risks in using it. And that would be step one. The next step that we're taking now quite actively is we've come to the realization that the patient has to know that too, that it's not just enough to communicate it to what has been our traditional and major interface, which is the physician. And so we're working very hard to bring patients to the understanding of this. And as I said, we've been doing it for a little over a decade now. But when I look back at the history of our company, and we have a credo too, just like Johnson & Johnson, we found a quote from our founder, George Merck, in 1950, and I want to share it with you. He said, "We cannot step aside and say that we have achieved our goal by inventing a new drug. We cannot rest until a way has been found, with our help, to bring our finest achievement to everyone." And I think implicit in that is not only access, but understanding of how to use the medicine. So, we haven't been paying enough attention. It's taken us a long time, at least 60 years, to get to this point. But now we're very much engaged. And of course, as a physician, I've seen over and over the evidence of patients not understanding their medications. I'm an endocrinologist, and numerous times I've placed patients on thyroid hormone and told them, you have to take this every day of your life. It's substituting for a hormone that's circulating normally in your body, and I can't tell you the number of patients who, when they start an antibiotic, say, uh-oh, that's going to interfere with my medicine. I'm going to stop taking my medicine for the next 14 days. And I'm sure you've seen the same thing in patients who say, well, my goal is to get my cholesterol down, and I start a cholesterol medication, and I go until my cholesterol hits the goal, and then I stop taking the cholesterol medicine. So it's something that we all know, and I'm glad that we are finally getting to the point where we're trying to intervene. We have challenges not only in the language that we use and the way we communicate, but of course we're trying to reach people at a very challenging time in their lives. Very often they're still assimilating a new diagnosis, and there's a large emotional overlay in that. And even if we've got the language quite right, patients aren't necessarily in a position to accept the language or understand it. And of course, as George Merck said, our medicines, they don't work unless you take them, and they don't work unless you take them properly. So we are now in a situation where we're understanding that we are part of a much larger ecosystem, and it's taking care of the whole patient, not just producing a medicine that will help the patient. One of the things that I think the industry can do is not only help with that particular prescription or that particular disease, like how do I take care of diabetes, not only the medicine but the diet and the exercise, but many patients have a fundamental distrust of medicines. They say, well, this is a chemical, or this is something that's made by a for-profit company, and even though the doctor has told me to take it, there's a bit of a barrier between that medicine and the patient. And so I think one of the things that we can do is to get out the message about what stands behind these medications, helping to build some trust about it. We don't operate in a vacuum. The medicines and the vaccines that we produce have gone through extensive clinical trials. Many patients aren't aware of that. And then they have health authorities like the FDA in the United States that stand behind these medicines in terms of their evaluation. And I think trust levels would go up considerably if patients also had an understanding not only of why they need to take that medicine for a particular disease, but where this medicine came from and what stands behind it. So we're on a journey now. We're trying to improve this. We've had standard processes in the past. For instance, when we develop materials for patients, our testing has been, can we achieve 80% understanding by the patient of the risks that they'll be taking in taking medicine? But that, I would say, is a kind of basement level of where we ought to be. And we need to be incorporating other principles like applying health literacy principles in all of our materials, developing tools and services that support patients, such as online resources, mobile apps, etc. And then the third is supporting health literacy through research. Now, we've been involved in supporting research and being involved in research and health literacy for at least a decade, and I think many of you know about some of our early efforts in the beginning of the last decade in Switzerland and Austria in the European Health Literacy Survey. We're ramping up now. We're making health literacy much more a part of our mission, and we're taking it very seriously. At least I'm taking it seriously because my performance evaluation now has a component of how we're going to do as a company in health literacy. So we're making a commitment. Another thing that we've become aware of is, of course, our interface with the patient begins before that medicine is available on a general basis globally. It begins with the earliest clinical trial for a particular medication, and that's a chance to begin to get it right, or at least begin the refinement process. If any of you have seen the information that's given to a patient at the time of a clinical trial, it's really a wonder that they understand anything about it. It's filled with disclaimers and a long laundry list of non-prioritized risks. And we have to get better at that, and we are, and I think we can use that as an opportunity to begin to learn how to communicate with the patient at the time that such a drug becomes generally available. The other thing that I think that we need to do is really kind of clean up some of our own language. We talk about benefit risks, but in many cases, benefit risk isn't really the calculation. The real calculation is risk. There's the risk of the disease and the natural history of the disease and the events associated with that disease, and then there's the risk of side effects of the medicine. And you know what? If that balance isn't right, the patient shouldn't be taking that medicine. But for many people, the concept of benefit means something else, like something wonderful is going to happen to you when you take this medicine. That's not the case always. It's usually that you will not get some of the sequelae of the disease. The same way I hear some of my physician colleagues talk about drug holidays. Well, if you take a medicine, you're not going to be sent to the Caribbean the next day. Okay, that's not what's going to happen. So I think a lot of the issues also begin with us in terms that we introduce into the jargon of medicine that then carry out. So I think another thing that we're coming to learn is that there are many approaches to this problem of health literacy, and in the end, I don't think we're going to find one size fits all. I think that there's going to be a menu of opportunities, menus of ways to communicate with different patients. Certain things will work for some and not for others. And again, I can go back to my own experience as a physician and say that I've actually, in my office, never seen the average patient. And we have to learn that as well. So the last thing I would just comment on is our packaging of medicines. And, I'm reminded of many of you, I'm sure, have bought toys as presents for children or grandchildren, and then you're horrified to find out that self-assembly is required. And you know how complicated that is. But, well, imagine for patients to open this package, which is supposed to be their instruction sheet for how to take the medicine. We really have to get this better in terms of visualization, in terms of formatting, and in terms of our language. So, I'd like to close by saying I think that this is really a terrific assembly. I think it has the potential to be a turning point in this field. It can have great impact for patients. And I also hope it'll elevate things to the point that we have a healthcare policy that prioritizes health literacy. We share your goals of elevating patient health through patient literacy, and I can tell you on behalf of my colleagues at Merck that we're fully committed to this field, and we look forward to working with all of you. Thank you very much.
So thank you very much to the panel. And we have an opportunity now for some comments and questions for this panel. And again, I'd like to invite you to come to either the forward or the rear microphone and make those comments. I'll make some announcements while people are moving to the microphones. To get a copy of the international paper on health literacy, the Andrew Pleasant paper, you can go to the Institute of Medicine website, IOM.edu, and I presume search for the Health Literacy Roundtable, and the under IOM.edu/World Health Lit, I think is the term, but you can also go to the website and search for the roundtable and then search for the paper as well, which is the way I would do it. There will be at the conclusion of today's meeting, at the end, there will be a bus for those folks roundtable members and speakers who wish to return to the hotel. And then the slides will be posted on the roundtable website, also on the IOM.edu website. So copies of the slides for those who wish them will also be available. Professor Nutbeam?
Don Nutbeam from University of Southampton. I actually had a question for Kristine about the European survey, and it's really along the lines of why does anyone care about health literacy? And I'm just interested to know, and the answer to this may be no, or it may be your answer is ask Jürgen. But you showed us some data that showed there's a social distribution of health literacy in the population, that those who are wealthier, better educated, have higher levels of health literacy compared to those who are a bit more disadvantaged socially. You also, I think, showed a distribution that showed health literacy status was related to perceived health. And I just wondered whether you'd begun to blend all of that analysis and started to look at the relationship or whether or not health literacy acts as some kind of mediator that might help those who come from more socially disadvantaged backgrounds, might protect them somewhat in relation to their health. Have you looked at this at all so far? I know it's early days in your analysis, but it would really matter, because if we identified that having higher health literacy status, even when you're poorer, actually protected you or promoted your health, I think that's a very profound finding on a population basis.
Yes, I will hand over the detailed question to Jürgen Pelikan, because it is indeed something we've been looking into, and we saw that there was this strong social gradient, and it's a double burden for some of our people in the study, that they are aged or they have low education or socially deprived. So Jürgen, please explain.
I think I can answer the question of Don partly. Because, of course, what we did, we were looking at consequences our health literacy has. Beg your pardon? Yes, okay. Is it better now? Yeah. Yeah. So we were looking at 2 or 3 things. First, we were looking at health literacy, what are the distributions? Then we are looking what are the determinants of health literacy, and we found, and I think that's very important, we found social gradients. You see, health literacy is not a dichotomous concept, it's a more or less concept, and therefore we found very interesting social gradients, and we found that health literacy has consequences. It has consequences for some health behaviors, especially for physical activity. There are positive correlations. It has some correlations concerning body mass index, but the evidence concerning alcohol and smoking is very different in different countries. There's very contradictory evidence. The other thing was we were looking how is health literacy related to health, to self-assessed health. There is a bivariate correlation, quite high, but you see the interesting thing is even in a multivariate analysis where you put in social determinants of health and even put in the NVS test, what you find is that after age, Health literacy is the second important predictor for self-assessed health, and the NVS test has no significant better concern. I think that's one part of the answer. So health literacy has the potential to be an intermediate variable to do that. But of course, concerning your question, we have to do a little bit different analysis to show what it does with people who have low, if their health literacy is different. Yeah, I know what kind of analysis you are looking forward. And of course, to say the last important thing we found, you found it in the States, of course, all the time, mostly too, there is quite an interesting relationship between health literacy and use of healthcare services. So people with higher health literacy have less use of healthcare services than people with low health literacy. So that's a very, very interesting point, I think, especially for costs and for our healthcare system.
Thank you very much. Let's go to the rear microphone.
Yes, my name is Elena Rios. I'm president of the National Hispanic Medical Association here in the United States. My question has to do with the World Health Communication Association and your concepts about the mass communication revolution and media now having a global consolidation. Here in the United States, we've had a rise in ethnic media in our communities of racial minorities in the United States, not just Hispanic, but Asian, African American. We have a long history of local newspapers, magazines, some of them are even national. We have national TV for Spanish language, Chinese language, other. My question has to do with how do you see measuring the impact of ethnic media and interconnecting with mainstream media at the national level in our countries. We've been asked, we're working on childhood obesity and changing behavior, and not to just look at ethnic communications, but to try to bridge to the national level. Especially in the United States, our country is becoming more and more diverse. And we can't afford to just continue to believe that making changes in the Hispanic community means just looking at the Hispanic media. So just wondering, there is an online service in the United States called New American Media that's looking at across ethnic media. But I'm just wondering from your perspective in other places, is there a connection between what's happening at local level ethnic with national level, and how do you measure the the impact, or how do you move the agenda forward?
Great. Thank you for the question. A tough question, but a couple of things. One is that clearly taking a page out of the book of the hazard merchants, say, how do we really segment populations? How do we develop audience-centered communication strategies? How do we understand better what the needs of our users are? And I think that you have to go back down to that. That in essence, this notion about really talking to the people that you are trying to target and get a sense of where are they getting their information from. I mean, we recently did some studies on immunization programs in Europe, and particularly focused on Roma populations. And there's a lot of concerns, or there's a lot of data which shows that certain Roma populations are unimmunized or under-immunized. And in many cases they were labeled as quote unquote hard to reach populations. And we quickly started looking at that by talking with Roma populations and doing focus groups and looking at what people's perceptions and behaviors were around vaccination. And we quickly learned that this hard to reach is a bit of a difficult framing of the issue, and that we recommended right away we start talking about poorly reached, that it's really about the system and our inability to reach people or understand where they're coming from and stuff. So in terms of the influence of local media is very important in many circumstances, but certainly we're all engaged in a global environment. That's why I'm sort of pushing this notion about us, health literacy as being a global issue. And I'd like to come back to separating, for example, the United States and the rest of the world in terms of the report that Andrew's writing. I don't think that's a good idea myself. I mean, it's already done, but I think that, we're all in it together, and we shouldn't be, I remember living in New York, and I had a New Yorker cover that the New Yorker's view of the world was 5th Avenue, 6th Avenue, 7th Avenue, China, Russia, it was like, we get a very narrow perspective on stuff, and I think that it's time to open up that perspective, because that's some of the problem and stuff. But I digress. So all I was to say is that I think you need to ask people about where they're getting their information, understand what channels they're using, who influences them. And then we do things like media audits, where we look at as who's speaking and who are the spokespeople, and we try to find some balance of that. And I think that really you're guided by the target population, and you want them involved in the planning, and you want them involved in the implementation, and you want them involved in the evaluation of the program. I think we've all learned that over time. We learned it over and over again. I think that I think there are answers to those questions, but I think we need to talk to the people who we're concerned about and are trying to target and trying to engage with and stuff. Just the last thing, there's a big role for mediators in this, and is a temporizing function. I don't think it's a long-term function, because most of the populations want to be mainstreamed and stuff. But there's some people from the community that can be that intermediary when you haven't developed those skills in terms of the community resources themselves.
Great. So again, back here, I'm going to take another 2 questions back here, Rima, and then I'll come back to you if you want to sit down for a few minutes. So.
Hi. Again, my name is Sabrina Kurtz-Rossi, and this is a question for Kristine. I was wondering if you could tell us a little bit more about this survey. I understand there's a survey asking the question about an international health literacy platform. I, again, feel that's very important in terms of health literacy professional and organizational development, and it would be, I think, important for everybody in this room to inform that survey, but also I think it's a great opportunity with folks listening in on the web if you could tell us a little bit more about it and how to access it in order for more people to give you feedback.
Yes, okay. In the last 3 years, when I've been part of the health literacy community and working as coordinator for the European project, I've attended international conferences, met international stakeholders in the field, and I always saw a potential for us to work much closer. And especially when now sharing results, discussing tools to measure, policy frameworks and activity plans, how to develop curriculums, there is so much to discuss. But how could we meet up? And that need, I was not the only one having that need, so we discussed how to move on. And I was approached by Professor Jill Rowlands from South Bank University in London to see if we could make a federation of networks. So having the Health Literacy Europe network with her UK network and so on. And I said, well, maybe that's not the best option. Let's look out there and see what could we do, what is the need. Is it a federation of network? How formal should it be? Should we listen to Frank and Apfel saying, no, not systematic too much at this stage, or should we really go for an organization? So we made a small inquiry and in SurveyMonkey, very low key, and it's being distributed, and I can send out the link to the organizers here and they can send it to you. And deadline would be beginning of October, because I've been invited to come back to the US for the HARC conference in Bethesda. And there I would meet with some of our American colleagues, and Jill Rowlands would be there as well. And then we could look through the results of the survey and come up with some recommendations, and I would share that report with the community again. So it's all very low key, but just to grasp the momentum which we have in Europe, and which I see you have here in the US as well, and in Canada, and our Australian colleagues. So what can we do, and what can we achieve? So the topics are what kind of networks are you involved in? What field? Is it policy, practice, research? What should that organization be doing? Should it be free membership, or how much would you be able to pay for it, or would we like to pay for it? Is it the time for a journal now? I know the Journal of Health Communication have really pulled a lot in that sense in the field of health literacy is it now the time for a journal? Would we actually submit articles to make an impact factor? So these are the questions. It's 14 questions. It should be a reasonable time to do it. Thank you.
Thank you for that comment. And Kristine, I appreciate your offer to make available some additional materials, and we'd be certainly, I think, glad to distribute them to those attending. So go ahead.
Yeah, just to say that I'm certainly not down on networking, and I've already signed up to your network, but I just don't want us to see that people can need certain kind of credentials to be involved in health literacy, to formalize it to the point where we start excluding people and trying to hem it in as a profession that I'd like to keep it open and networks perfect. I think that's just a great way to expand and develop a global consciousness awareness.
Yeah, to your point, Franklin, as well, the Roundtable doesn't have any requirement for credentials as far as either participants or sponsors or people in the meetings. And while we very much appreciate the opportunity to draw upon the expertise of real experts in the field, I think the strength of the dialogue comes, quite frankly, from the mix of backgrounds and people joining together in the conversation. So your point is well taken in that regard, at least by me anyway. Back here, and then we're going to come to Rima.
Thank you, Dr. Isham. Jennifer Cabe with Canyon Ranch Institute. This was a terrific panel. It's great to hear people talking in a very focused way about innovation. My question, I think, is perhaps most for Dr. Isaac and Dr. Rosenblatt, but would welcome anybody else chiming in. Dr. Isaac, you in particular talked about the employees of Johnson & Johnson, engaging with those employees to try to improve their health outcomes. And Dr. Rosenblatt, you did as well, particularly talking about employees' interest in health literacy and how they're influencing the company's thinking. Can you speak a little bit, either of you or both if you would, to the crossover there in how your employees influence internal policy about what the company should be focused on, perhaps with health literacy, health outcomes, and also from a programmatic standpoint? I was really, really struck, Dr. Isaac, in that you didn't even seem to particularly distinguish or put up a firewall, which I think is very positive, between the employee wellness and then also what you are actually offering as a business-to-business product for employees of other companies. I'm not sure that that was a correct perspective, but I thought it was, and maybe I made it up because I would be so impressed if that was the case.
No, let me try to go back to the question at hand, which I understand you're looking at. What are our means or the channels of getting the employees engaged internally, whether it's in their well-being or in outcomes, but how we are not separating between what's within or goes commercially outside. Is that correct?
Yes, and how you're also accepting the ideas and engagement of your employees who really understand the mission and would be willing to care about it.
Yeah, I'll reflect briefly on that. Part of the engagement and participation strategy we have, one has to do with the entry point. So the entry point for us which really covers a lot of health literacy related aspect is our health risk assessment process, which is really about people taking an online survey and responding to a number of questions about modifiable risk factor and behaviors. And the way we got them engaged in this was by offering a discount on their health or medical contribution that they receive upfront if they do not participate in the assessment and or in addressing any risk factor that applies to them, which then they need to reach into a health advisor, a health coach, or online tools, which the ones I shared with you, then that amount is actually taken away from their paycheck. With applying this process for the last 17 years, got participation rates from about, back then in 1993-94, from 26% participation rates to the following 3 to 5 years to about 93% participation rates with a 90% satisfaction of the process itself. We usually do, an end user type of satisfaction survey. In the last 10 years, the approach has not changed. We still maintain that $500 discount upfront, and the participation rates now is between 80 to 85%. We usually also would put the data of the outcome by site and by company on their website to share with them what is the population risk factor and what's the target for Johnson & Johnson as a whole. We had healthy people 2005, and then we have a healthy people 2010, and now we're moving to the healthy future 2015. So with that, we also have in our strategic think tank, we actually have representatives from the employee population that sit down and say what they like, what they don't like. If we put a tobacco-free policy in place, we want them to be engaged. So actually we bring in the smokers and the non-smokers to sit together, work with us to say, what do you think? Do you think this is the right thing for Johnson & Johnson or not? And we get quite a bit of really engagement by our employees in that regard. The other piece is of also that I did not talk about in details is about trying to put some of the communication and the promotion everywhere where people are and where they go, from cafeterias to bulletin boards to, bathrooms, and anywhere that you can go, you'll find communication to employees and actually giving them ways and means to address a specific health topic or anything they want and making the referral. So that process has worked and continued to work very well for us. We do not differentiate between internal and external because those tools and products are Johnson & Johnson's. They are internal. We apply them. I think the kiosk is external to Johnson & Johnson, and that's just in a trial testing in the UK and France to also assess to see, do people feel that this is really adding value to their day-to-day assessment of their own personal health risk or not? And then on an annual basis, we do conduct a survey to look at, do you believe as an employee that Johnson & Johnson cares about your health and well-being or not? And we use that kind of to assess where are we, and you will see big variation from company to company, which really then reflect their leadership and or our program is not working for some reason, and that keeps us moving. I don't know if I answered your question, but I hope I did a little bit.
Kristine, do you want to add to that?
Yes, please. As part of a spin-off project from the European Health Literacy Project, we are engaged in a joint venture on health literacy with the CSR Europe, Corporate Social Responsibility Europe, and in a steering committee with MSD and Edenred and Nestle and Microsoft, with 75 members in this organization. And we made a scan of how much the companies are involved in health literacy. And it turned out that the front runners were indeed our colleagues here, Johnson & Johnson and Merck and Nestle. And I want to congratulate you because I think it was very clear from the fine presentation we had that you really managed to move health literacy from the fitness room to the boardroom. And my question to my colleagues here is then what message can I take home to the other 70 companies, car companies, telephone companies who do not have a health-related product to actually move from having health and health literacy as a nice-to-have projects to a need to have where it's part of your corporate DNA. That would be my question to both of you. Thank you.
I'll take it.
I think we very similarly have seen our employees taking more and more advantage of the resources. Once they're available, they really get taken advantage of, and we have some early indicators that they're having an impact on health. The other thing I'll say, though, is it makes me very envious of the single-payer health systems because once an employee starts engaging in trying to improve their health in the United States, we've actually had to make available health advocates to help them navigate the system to get the care that they've identified that they need. So there's a whole other side. I don't know if you call that health literacy or literacy about insurance companies, but it's a real factor.
I'll just add to say the message to those corporations that may not be in the healthcare industry is really going to have to make for them the connectivity, the linkage between good health, the theme of caring, as well as the engagement and impact on people happiness, as well as productivity in the workplace. That actually worked for us because when in the U.S. our messaging is centered around healthcare. When we talk to our senior management, healthcare cost and the impact, which is very evident, and we have been able to show it. When you go outside the U.S., you cannot talk about that. You really talk about engagement, about using it as a way for recruitment, for retention, especially in emerging markets, and it does work. And I think it has to be part of a business imperative. Otherwise, it does not last.
Thank you for that. Rima, you're next. Then I'm going to go to Cindy, and then we'll go back to the back microphone. Nope, I'm going to skip Cindy. Okay, Rima.
Sorry, this came off in my hand. I do want to make. Oh, I didn't quite break it, I don't think. I really want to celebrate and congratulate Kristine and Jürgen for your findings and your report. And in celebrating it, I also want to highlight the fact that good science is really built on the confluence of findings. So sometimes the question is, can we replicate the finding? But another question really is that, can we triangulate? So can we reach the same insights and the same findings from different methods and different perspectives? And I think you've shown us that the answer is an enthusiastic yes, because the analysis that I was part of looking at the health literacy of populations in the US, in Canada, in Australia, in New Zealand, in the Netherlands, from the perspective of measuring people's skills, came to the same conclusion that you did in measuring people's perceptions. And indeed, we may well say very strongly that literacy may not be a mediating factor, but that literacy may well be a social determinant of health. What we have not yet been able to answer, however, is the question of what action can we take, and what meaning can we make of this? So, for example, is someone reporting to you that they don't have access to information that they need because of their own lack of skills, or because the information is so poorly constructed that it's not accessible? And so that really does have profound implications for action. And so I think that our next step is to make meaning of these findings and to make sure that we are not myopically focused on the skills or perceptions or experiences of the individuals and therefore patients and citizens that we've measured, but look very closely at how we can break that link between the social determinants of health as health literacy. And we can break that link perhaps by changing the demand side, by improving information and the accessibility of information, the way we communicate. But I celebrate the fact that good science has just been made, because indeed there is a confluence of findings, and we really now have to take that and move forward. So thank you so much for all of your work.
Please go ahead, Kristine.
Thank you very much for your support. And I remember I met actually Rima Rod in Zurich 3 years ago, and Don Notbeam, and he said, Kristine, just get that study up and running and we will see the results it's needed. And now we are here to celebrate, so thank you very much. I think you are really right in not blaming our citizens and blaming the people, but I think the most shocking effect, that 47%, was to me as being part of the system. Oh, we're doing so wrong, If it's only 47% or 53% doing well, what are we doing? We have to do something. Where should the change start? Yeah, with me. And with you and with us. So we have to keep that in mind when now looking at the system. And when we do the comparative results, we also try not to insult our partners, so not blaming Bulgaria for doing wrong, but actually using that comparative study to look at what are the best practices in a different system, who can we learn from, and not trying to just look at the worst and blame, but really try to take the asset approach of not beam and saying what can we do good.
So Kristine, could you just comment a bit further on that track? Because I think we heard from the last panel a number of the countries trying to characterize the degree of the problem in health literacy as a first step for engaging policymakers. That's a supplement to the point that actually Don and Rima are making.
Yeah.
So what about that impact on these countries so far that have been participating? Not the science and how it actually works, but the engagement of those in policy positions and leadership positions and a position to start thinking about what to do about the numbers.
I think those who constructed the project was very, very clever to make a sustainable approach into it. So it was not only about measuring health literacy and then we would have the data available and then our politicians would say, and so what? We actually have that dialogue, not creating the network at European level, so having professionals to share and discuss, but also the platforms, the national advisory boards in our countries who participated. And those advisory boards are very, very different depending on which country, because it had to be linked to already existing systems, or if there was nothing as such, you had to develop something. So in Ireland, Jennifer Lynch, she was on the board, and you were really doing a great work, and the Health Literacy Award, and it served as a case we could present to the other countries. In the Netherlands, where I'm based now, they had already a group of researchers and a literacy group also very active, and they had made an attempt to make an organization or an alliance, the Health Literacy Alliance, and they have already 60 organizations engaged. And then on the other hand, we had Bulgaria and Poland where nothing was established, and they were basically waiting for the data, and when they had the data, they could go to the politicians. And I know Jürgen Pelikan can also give an example of Austria, but Austria was then very, very quickly taking up the results and adapting it and actually making it into health targets. So they are now our best practice in terms of policy guidelines. So this, the whole approach of the project helped us to give that policy impact. And I hope, that could give examples also for you.
Thank you very much. Back to the back microphone for the last two comments.
Great, thanks. Joan Kelly, board member and head of Consumer Experience for Humana. In hearing the dialogue this afternoon, it seems to me that we could look to a program that we did at the World Economic Forum, the Worldwide Wellness Alliance, that we brought together 60 multinationals to begin sharing data and information on what works in our work sites for wellness. And Scott Ratson from J&J worked with me and a small team to create this platform where we can share best practices, and it's a great way for us to come together. And I apologize, I'm going to miss this afternoon, so I wanted to make sure you could have dialogue about this. But we could all create this type of platform, possibly even use what we're using at the World Economic Forum, so we could see what works with different populations in different areas for health literacy, so that we can really have all boats rise and not use different resources for things that we're all creating ourselves, but to borrow from one another.
Thank you. I think we'll take Ruth's comment.
To get it on the record. Thank you. So thank you all very much. So this follows up very nicely to what you just said, and it's really a comment about some work we've done at the Roundtable around medication labels as an issue at the intersection of health literacy and patient safety. And the lens that we all try very much to be a part of, which is being patient-centered and really trying to understand what the voice is of the patient, the ultimate consumer, and also realizing the multi-billion-dollar industry of pharmaceuticals, and applauding the work of the membership that we've had of members of the pharmaceutical industry who've been a part of the Roundtable, and also setting forth a challenge. We've still got a lot of work to do, and we so much need the partnerships, and it's incredibly helpful to hear from you all what specifically this group does to advance making health literacy a reality for everyone on specifics like clinical trials, the engagement of people from the very beginning, their voice at the table, understanding how we create labels that truly are understandable, actionable, safe, effective, and that we all benefit. So I want to thank you for the participation you all have had, and also invite you to help guide us in what we as a group do to continue to advance that agenda.
Thank you. So with that, what we are going to do is take a very brief break so we can change the panel and change the slides. So I'm going to suggest 10 minutes. And then we're going to come back. And I want to give you a little bit of a warning here. We've got 3 outstanding leaders in the field to kind of jumpstart us on the question of where do we go from here. But I've been known to call upon people in the audience, whether or not they're interested in making a response, about what their ideas are, because this is our opportunity to actually take in all the things that we've heard today, some of the conversations, to reflect a bit about what we've heard and its implications. Come to the microphone and express that, because that's one way that we can make sure that our document includes your best thinking, not only of the 3 very smart leading people that we're going to have on this panel, but reflects the wisdom of this audience more broadly. So I ask you to think about that as we take this 10-minute break, and we'll convene in 10 minutes. Thanks very much to this panel. Please join me in thanking this panel.